So good afternoon, everyone. It's our pleasure with the ERN Reconnect and the Sjögren disease group to meet again with this new webinar. It's a beautiful webinar with a great couple of speakers because we will speak today about Sjögren in childhood. And for that, we have the opportunity to have two points of view. First, we will have Anna Vieira from Sjögren Europe, who will give us the view of a patient. And then we will have Dr. Eduardo Marani, which is a pediatrician, rheumatologist pediatrician in Mayor Children's Hospital in Firenze. So the floor is yours, Anna. We will first start with Anna, and then we will have Eduardo, and then we have time to discuss together. Thank you again.
Thank you, Gaetan. Thank you, Eduardo. I'm very happy to be here today. I will now share my screen. I hope you can see it now. Can you please just confirm that you can see my screen?
Perfect.
Yes. Okay, so while thinking on what to present today, I have decided to present my own patient journey because I think a concrete example will make things easier for the audience to perceive what the journey has been. This is a picture of myself and at my brother's birthday. As you can see, my lower lip is very swollen, and according to my mother, this was like this since I was born. She usually say, when I saw your lips, I thought you were not normal. So I have always been a fragile child, very skinny, the shortest in the room, and I was frequently ill and feeling unwell. And plenty of non-specific symptoms such as recurrent nosebleeds or underweight. I was always underweight until 2023. I had lower immunity, that's why I was always sick and feeling unwell. I had frequent mouth sores, and joint and muscle pain were always there. All these symptoms were very so unspecific that no doctor was able to relate them. And I usually say that I've had growing pain in my muscle and joints till I was a grown-up, because they always said, well, your pain, it's growing pain, it's part of the process. Over the time, other complications appeared. This is me in my teenagehood. I chose this picture because I'm kind of expressionless due to a face palsy. So by this age, I started to have swollen, painful parotid glands with fevers, but that were always treated as a viral or bacterial infection. So plenty of penicillin and other antibiotics. I've had extremely cold feet and hands ever since I can remember. Now I know it's Raynaud's. I've had a dramatic dental decay by the age of 12. So basically every tooth in my mouth had cavities, with my parents being accused of not doing a proper vigilance to my oral hygiene. Fatigue was already there. Dry skin as well, and the face palsy as a consequence of the numerous swollen parotid glands. Cold sores, lip herpes were also frequent. They still are. I had persistent headaches since I was 15, more or less, as that's what I can recall. Cracked lips all the time. Chronic anemia, difficulties in applying and using menstrual tampons. So I guess some level of vaginal dryness was already there. And of course, the joint and muscle pain kept following me throughout the years. Finally, in 2007, I was at 32 years old. I was diagnosed after an emergency hospitalization due to a suspected pulmonary emboly. I've been in the hospital for 2 weeks, and they run a endless number of tests and exams with no objective conclusions. And I was sent home, and my rheumatologist referred me to a rheumatologist. Although during the time I was at the hospital, I complained of different symptoms, such as frequent bleeding during sexual intercourse. They checked I had abnormal liver tests and proteins in blood and urine. Feeling of faintness and lightheadedness were there daily. And in fact, I actually fainted twice while I was hospitalized. I was underweight by this age as well. I had difficulties in thermal regulation. Either I was too cold and I couldn't get myself warm, or I was on the other way around, very, very hot. I complained of vaginal dryness, blurred vision, and severe photophobia. Muscle weakness. I remember I wasn't able to open a water bottle. I had to ask someone else to do it for me by this time. Enduring headaches, dry eyes, dry mouth, and dry nose, severe muscle and joint pain. I remember that after this hospitalization, I was unable to drive my car for 2 months because the pain in my hands and the stiffness was so severe. I wasn't able to use the driving wheel or the gear handle. Persistent dry cough. And by the time I was hospitalized, I've had 2 pregnancies already. And despite I was weighing 45 kilos when I got pregnant, my babies were born really big. They were both over 4 kilos. So then after I was referred to a rheumatologist, he asked me several questions and immediately suspected I was suffering for an autoimmune disease. And he suspected of lupus. So we ran a very complex blood work, and the results were very, very objective and left no room for doubt that it was Sjögren's. So I've had high dimer values, high SED rates, ANA positive, rheumatoid factor positive, SSA and SSV positive, Rho 52 and 60 positive, low C3, leukopenia, and high beta-2 microglobulin as well. Long-term outcomes are not well established or even clearly known in childhood-onset Sjögren, so I decided to share with you all the symptoms I'm living with today, so you can understand what is to live with Sjögren. So I still get this recurrent swollen and painful parotid glands, as you can see in the picture. Disabling fatigue, so over time, fatigue become more and more severe. I suffer from bloating, urinary urgency, recurrent urinary tract infections, difficulties in holding urine, urinary urgency, incontinence and fecal incontinence, difficulties in emptying bladder and my bowel as well, diarrhea, frequent diarrhea. I've had corneal ulcers, nausea, stomach upset, and intestinal cramps. I still get recurrent nosebleeds, crystal arthritis, pseudo-gout, mainly in my shoulders and my feet due to chronic inflammation. At least that's the explanation my doctor gives me. And also difficulties in chewing, concentration issues, rosacea, forgetfulness, purpura, Raynaud's. Now I know it's Raynaud's. Gum recession, broken teeth, memory issues, persistent lymph nodes inflammation in my armpits. So from times to times, I need to do a biopsy just to control what is there. Difficulties in swallowing, sexual impairment, speech issues. And because of so many years of disbelief I have a low self-esteem, low self-confidence, and a negative body perception. As you can imagine, all these symptoms have a massive impact on my personal, professional, and social life. And your mental health really is at stake. In this timeline, you can see that I was born in 1975, and nowadays we are in 2025. I will be 50 years old in August. So my diagnosis date or year is 2007. I usually say it took me around 2 decades for the diagnosis, because the most obvious symptoms started at the age of 12, although I had other minor symptoms earlier on. But it took me, after diagnosis, 10 years to get proper access to treatment. And to do so, I had to change rheumatologists, and I had to change to university hospital with a Sjögren's clinics, because the rheumatologist who diagnosed me always sent me home with artificial tears, artificial saliva, and painkillers, and that was all. So only in 2017, I had proper access to care and treatment. 3 years later, I was enrolled in a phase 2 clinical trial. And from 2017 until today, my quality of life, despite all the symptom burden, really improved, because I'm being followed in different specialties and with people and specialists who really know what Sjögren is. So this timeline is for you to understand that I've had a late diagnosis. It's kind of a recap of what I've said earlier. I've had a late access to care and to treatment. And because of that, I have a high symptom burden and irreversible damage as well. My take-home message will be that early interventions are urgent. We really need to diagnose earlier on. Reliable diagnostic tools for childhood-onset Sjögren's are missing. Classification criteria is missing, but we are already working on it. Identification of red flags is urgent, so that children don't have to wait as long as I did for a diagnosis. Damage assessment tools are urgent as well. Lack of specific centers for referral of this treatment of these children is something that really worries me. If we look at Reconnect full members, which are quite a lot, only 6 of them covered childhood-onset Sjögren. And from these 6 centers, we're talking about 3 European countries, Finland, Italy, and Spain, which leaves me wonder, where are all the remaining children in Europe from the remaining countries being followed? Are they misdiagnosed, undiagnosed? I don't know, but this really worries me. And last but not least, non-existent awareness. Nobody's talking about childhood-onset Sjögren in Europe. We are making noise today because we want to be heard, but there is a long way ahead. My last message will be, life with Sjögren's is more than meets the eye. And because of that, I am sharing you this beautiful vase that is perfect and shiny on the outside, but broken and damaged inside, as an image of what a Sjögren patient looks like, whether it's a child or an adult. Thank you for your attention, and I'm happy to take questions in the end. I will stop sharing my screen now. Okay.
Thank you so much, Anna, for this very important testimony. And so now it's Eduardo who is taking the the mic for the presentation for the clinician view, and we hope we will have some key to improve the management of Sjögren disease in childhood thanks to this discussion. Thank you again, Anna, and we have the question at the end of the presentation of Eduardo.
Good afternoon, everyone. Can you see my presentation?
Yes, perfectly.
So thank you very much, and Coralie for your Gaetan for your introduction, and Anna for your excellent presentation. We cover most of the topic I will focus on during these few minutes, and I'll explain what we know about pediatric Sjögren syndrome, but more importantly, I will focus on what remain unknown for these patients. So we are aware that the primary Sjögren disease in adults is a complex disease with it affects 1 in 400 people around the world. It's estimated with a striking ratio toward female, as the ratio is 10 female for each male affected, with 95% of patients are middle-aged women with increased risk of polyautoimmunity and a high risk of developing at least one life-threatening complication during life. On the contrary, childhood-onset Sjögren disease represents just 1% of primary Sjögren disease, and the ratio narrow to 4 female for each male affected, but these patients are severely affected with 90% experience systemic involvement. As you can see from this large cohort of patients, 1% of pediatric or the cases are received the diagnosis during childhood, with a mean age at first signs of symptoms around 13 years of age, and a mean age at the diagnosis of 14 years. However, as Anna just recalled in her touching presentation, maybe childhood-onset Sjögren disease is overlooked as it's a rare disease, a complex disease, and physicians are not aware of a peculiar presentation during childhood. This is the result of a survey by Sjögren Foundation, and when adult patients were asked to recall back the onset of symptoms, most of them just dated during adulthood or young adulthood or adolescent or even childhood. So this means that diseases start many years before we expect to what is reported in literature nowadays. And the difficulties in the diagnosis are related to the complexity and the heterogeneity of the disease. I just summarize here 4 patients who are in follow-up in our clinic in these days. And if you look at the clinical feature, laboratory exams, ultrasounds, minor salivary gland biopsy, no one of these patients just mirror another one. I could have taken more cases and the result would be the same. Each pediatric patient with Sjögren disease has a different combination symptom who make really difficult to get the right diagnosis if we are not aware of this. When to suspect Sjögren disease in childhood? You can see here summarize the main presentation, main feature in pediatric age. But I don't need to recall this, as Anna in her presentation just summarized many of these features, like recurrent parotitis, the nerve palsy, dysautonomia, fever, fatigue, weight loss, or increased serological activity, recurrent oral ulceration. So we need to think about Sjögren disease when we are facing children or young adult or adolescent with such feature. We should not think about childhood-onset Sjögren disease as a mirror of the adult counterpart disease. As you can see here summarized, adult patients are more prone to experience Zika symptoms, lung involvement, articular involvement with arthralgia or arthritis, and even fatigue, while children has more frequently glandular involvement or just constitutional involvement, such as fever, involuntary weight loss, or night sweats. Here you can see how is considered the evolution of the disease in terms of Zika symptoms and biological activity defined as positive anti-SSA antibodies according to age at disease onset or disease diagnosis, which is known from the literature is that younger children, younger patients has less Zika symptoms and more biological activities. And this is in accord with the theory of the preclinical stage of the disease, where the autoantibodies are present, but patients do not experience any symptoms as the glandular damage is increasing over time to get a threshold in which the symptoms start to appear. But it's not completely true in children, because as shown by this large cohort of pediatric patients, children with a disease onset between 5 to 9 years of age as expected a low rate of dryness, but still they are prone to be autoantibodies negative. So this means that we really need some biomarkers which can allow us to an earlier identification of these patients and to make a differential diagnosis with other conditions such as juvenile recurrent parotitis. Another aspect of a childhood Sjögren disease is that the clinical heterogeneity means that pediatric patients do not satisfy the available classification criteria. Just a large proportion of patients did not satisfy the latest EULAR ACR criteria. This is due to the fact that several tests are difficult to perform in pediatric age, like shallow endoscopy, shallography, unstimulated wall salivary flow, or the result of the test is difficult to be interpreted in pediatric patients. This is the case of a minor salivary gland biopsy, where a lower threshold, a lower focus score might be diagnostic for Sjögren disease, or the cutoff for Zika testing, which are not be set in pediatric age. Another issue when thinking about the diagnosis of Sjögren disease is that we motivated from the adult the use of Meyer salivary gland ultrasound to faster the diagnosis of Sjögren disease. This is an inexpensive, non-invasive, and easy to implement tool was shown a good sensitivity in adult patients. Also in pediatric, the bilateral parenchymal inhomogeneity is a hallmark of a disease, but still we are not sure about the direct application of the Homeract score to the pediatric population, and we are not sure about the role of ultrasound in disease monitoring and in assessing response to treatment. There are several other issues in disease monitoring in pediatric patients. We lack a tool age-specific patients-reported outcome, and age-specific activity and image score. We don't know if the cluster of disease identified from the group of Professor Nocturne in adults exists also in pediatric population, and if belonging to a specific cluster in pediatric confer different risk of developing lymphoma or Zika symptoms or other extraglandular complication in adulthood. We lack a specific program to monitor patients, pediatric patients, to intercept Zika feature or extraglandular involvement. And as already said, we lack biomarker to assess activity and organ involvement, and we don't have any data on risk of malignancy in pediatric age. Another key point to be touched during this conversation is the treatment of Sjögren disease in pediatric age. We know from the guidelines, the published guidelines, that a multidisciplinary approach and patients empowerment strategies are the cornerstone for the treatment. And the pediatric patients need periodical monitoring to rule out any glandular or systemic manifestation. And this means that a regular follow-up with dental and ophthalmology service is critical to monitor disease and to prevent oral or ocular complication. We also need to update immunization. But what is not clear at all is the use of systemic immune modulatory treatment in these patients. As reported by this survey run between a US healthcare provider, the indication to use systemic treatment are really variable, and also the type of treatment, it's really different, both in to treat parotitis and or treat extraglandular manifestation. Furthermore, the level of evidence guiding us while treating our patients is really, really low, as is mainly derived from case report, as summarized by this systematic literature review. As Anna just say, we don't have any specific clinical trial involving or including pediatric patients with Sjögren disease. So, but we need, I really want to focus on the fact that pediatric rheumatologists or physicians who are treating childhood-onset Sjögren disease are having a critical windows of opportunity, because we are able to treat the early inflammatory phase before damage is accruing, before irreversible damage. And to solve most of the question I raised during this webinar, we need to focus that multi-center and international collaboration are the key to answer many of these questions. And just to, for example, I want to highlight the role of this recently started project, prospective project run by the American colleague Matthew Basiaga, to highlight the long-term outcome of our patients. We don't have any data, as Anna just explained us. So before ending, I want to thank my colleagues in Firenze, in particular my mentor, Professor Simonini, and the amazing colleagues from the press Sjögren Interest Group or the International Childhood Sjögren Disease Work Group. Thank you for your attention.
Thank you, Eduardo, and thank you again, Anna. So it's time for question and discussion. first, maybe for Anna, regarding this very hard journey for patients living with Sjögren. When you were a child, did you often go to the clinician, and do the question of an autoimmune disease have been asked at any time of your journey, or you had to wait for being 30 to ask for this question of autoimmunity?
Yes, I had to wait till I was 32, and after that hospitalization. It's important to make it clear that the area where I live and your zip code also influences your health outcomes. Had no hospital nearby, so I repeatedly was taken by my parents to the primary care doctor. So there was no access to specialties doctors like rheumatology or other. And pardon for this worse voice. And my family doctor never suspected there could be some autoimmunity behind it.
So one of a key finding that Eduardo reminds us is the appearance of parotid swelling even in childhood. Did you have some parotid swelling, and does it make any comment for your parents? Because sometimes we have some parents coming with children and telling, okay, it may be a viral infection or something, and the idea of an autoimmune disease is not even asked. So
that's exactly what happened in my case. So every time I had this very painful swollen parotitis, and usually with fever, I remember I would stay in bed for 2 to 3 weeks. I was really, it were really tough times. But it was always seen and treated as a viral or a bacterial infection, so always antibiotics. I remember I was really young and they gave me these penicillin shots, other times oral antibiotics, but they never ever questioned themselves there that this recurrence could be an autoimmune disease. Never.
And you both, Anna and Eduardo, highlight the fact that we really have to work, and I think that Irene Reconnect is really the way to do. We have to work to improve the time for diagnosis, and so for people listening to us, maybe for Eduardo a question: what could be the red flags for diagnosis when for parents having a child with some symptoms? What are the symptoms that could make ask the question of Sjögren disease in childhood?
The main manifestation, I mean, physician, I mean, primary care physician, ear, nose, and throat specialist, and also parent should focus on is parotiditis. Definitely recurrent parotitis should be the first clinical feature to focus on to increase awareness. As I think, I mean, in our clinical practice, we often see that recurrent parotitis may have a peak, and then the recurrence just go a little, just decrease over time. So people just skip an entire phase of a disease because they have a recurrent parotitis since they are like 8 years old till 12, and then these patients just for a while they feel good, feel better, and then maybe they will come to the clinic, to the adult clinic later on in the life, and we just, because they were completely missed by the pediatric specialist. So we need to start working on this because it's the more typical as, and also the ocular manifestation, because Zika symptoms, but also when tested, most of the patients with corneal damage, just slightly corneal damage, as abnormal testing for TR production. So we need to start from this and expand into other not so common feature, or like it's easier to evaluate a pediatric patients with Raynaud for autoimmunity, or with persistent fever for autoimmunity. And in that case, the diagnosis the delay in the diagnosis is shorter. But with a specific symptom, we should focus if we think about red flags. It's my idea, personal idea.
Yeah, and maybe working with other specialists, as you said, with a ear and nose specialist, or maybe dentistry, that could be helpful too. And they often see children in daily practice, so good things to observe. And you explain us that finally maybe that Sjögren in childhood is not so over unfrequent, and we have to have this diagnosis in mind more frequently. But it seems that before puberty, it's something very exceptional. What is your feeling about that? Is there a threshold before, I don't know, like before 9 and after 9 years old, or even a younger age, like at 5 years or something? That could be something evoking Sjögren disease is something that is still possible.
We saw several patients with disease onset before puberty. This is true for people with from South American origin, or I mean not Caucasian origin. This as for other autoimmune diseases, they are associated with a higher disease burden, and they can start before puberty with recurrent parotitis. Recurrent parotitis might start before other as isolated feature before the development of the full-blown disease, like later on after puberty. So they start like recurrent parotitis, and you know, it's an unexplored field, because the younger children are evaluated for recurrent parotitis by ear, nose, and throat specialist or infectious disease specialist. So we don't know in that in a large pool of recurrent parotitis if we are missing some early onset Sjögren disease, because it's as a rheumatologist, we do not evaluate specifically that patients. No one refer a 6 years old patients directly to the rheumatologist. So we need to really to work on with other specialists, as already said.
Okay. Maybe again a question before moving to treatment regarding the usefulness of ultrasonography. So do you think that it could be something that should be added for every patient with suspected Sjögren disease?
I think also for you as an adult rheumatologist, the ultrasound gave a really a useful tool to evaluate these patients with a suspect of Sjögren. Yeah, for us, definitely, when we start apply in a more systematic way, salivary gland biopsy, and we also collaborate with colleagues to study minor salivary glands ultrasound in our patients, we felt the difference, because we don't have any guidelines to attribute a specific pattern to Sjögren disease, but it allows us to make a screening of patients with a negative echo and the negative blood results who are show a lower risk to develop Sjögren, while other patients with maybe some mild alteration in the clinical phenotype might have ultrasound abnormalities who can directly guide us to minor salivary gland biopsy, who is still the gold standard for diagnosis, even in pediatric patients.
Thank you. And so to finish the last topic regarding treatment, which is a hard one. So maybe for Anna, a first question, you talk about the participation to experimental clinical trial, which is something really important. So when you decided to be involved in this clinical trial, what was your greatest expectations, and especially what was the main clinical outcome that you wish to improve?
Well, regarding the expectations, I just wanted to get better because all the therapeutic approaches were exhausted. So my symptoms were getting really severe, and the approaches my doctor was using were not solving my issues. So we discussed what to do, and we've talked about methotrexate, rituximab, or this new therapy that this phase 2 clinical trial that was about to be launched. And I immediately told him, well, I would go for the novelty, because I know that for rituximab and methotrexate, the efficiency in Sjögren's is limited, and I don't want to go through all the well-known side effects and having a handful of nothing in terms of improvement. So I wanted to get better, first of all, and I also wanted to contribute to bring a drug to the market as soon as possible, because this is a huge unmet need in Sjögren's disease. So far, we have no approved drug, although phase 3 clinical trials are recruiting, thank God. It's about time. As for the symptoms, the most impactful thing for me is fatigue, and it didn't work in fatigue at all, but it did work in pain. So I was in pain 24 hours, 7 days a week with different levels of pain. So I was taking painkillers on a regular basis, and I stopped taking painkillers with this therapy. I stopped my medication for Raynaud. My lymph nodes, I had several huge lymph nodes in my armpits for many years, and they kept growing. After 6 weeks on this therapy, they all vanished. So I was then sure I was on the medication and not on the placebo. Otherwise, it would be really disappointing to have a placebo destroying these lymph nodes. And I used to do physiotherapy twice a week to keep my shoulder mobility before the trial. And during the trial, I stopped the physiotherapy. So I got my mobility back. And of course, my mouth dryness improved slightly. Not much, but it did. But most of all, my eye dryness improved dramatically. So I hardly ever use artificial tears during the day, only if it's a very windy day or if I'm in a room with air conditioning for a long period, I need them. I need to use my gel before I go to sleep in my eyes. But I mean, in every half an hour before the clinical trial, I was using artificial tears, and that is past. So, but fatigue remained really unaddressed. So, and that was a disappointment, to be honest. And of course, I had side effects as well, like recurrent urinary tract infections, rosacea, severe rosacea, but you can't just have the good side of it. And I can say that I felt almost healthy during these 120 weeks. So it was more than 2 years in this clinical trial, this clinical trial duration, I mean.
So there is time for hopes.
Yes, hope is permitted. I'm really positive about the future because there are so many clinical trials recruiting right now. So I just hope that we have very good news as soon as possible.
Thank you, Anna. And maybe a last question, because time is running. A question for Eduardo, again, regarding treatment. That is something that is also asked for adult patients, but what is the room for hydroxychloroquine? Because it looks like quite safe drug, so could it be used in every children patients with Sjögren, or only in case of systemic manifestation? And what do you think about the safety for long-term usage of hydroxychloroquine? If you start hydroxychloroquine at 10 years old, what would be the possibility for the future and the safety regarding notably ocular safety?
We are prone to use hydroxychloroquine in all our patients with diagnosis of childhood-onset Sjögren disease, as it seems to exert an action on extra glandular manifestations such as rain or articular manifestation. And so it's a standard of care for us in our practice. And we mutuated the experience from the lupus patients, and we are treating patients with the hydroxychloroquine with a dosage around or below 5 milligram kilo for days. Since several years, without any relevant side effect, we perform the ocular screening with OCT, computer tomography of ocular computer tomography, and without any significant side effect. I think because of the reduced dosage compared with the adults, we are not going over 200 milligrams every day. So it's well tolerated. We do not know the long-term efficacy in terms of change in the natural history of the disease. This is an open question, but I think no one is able to answer this question. And clinical trial or long-term studies are needed to solve this association with an improving objective outcome measure like disease activity or damage. So we use, but we don't know if change the game on the long term. Anna wanted to answer.
Yes, I want to add a comment because I see in the chat that there's someone asking about the psychological impact. And I didn't mention this, I didn't elaborate much on this, but I think psychological support for these patients should be a must. Unfortunately, in my particular case, I was referred to psychiatry too late, I would say. It was about 3 years ago. I was really in the mud, I would say, and my rheumatologist referred me to psychiatrists, and I'm medicated. And ever since, I enjoy life much more because you are used to endure so much over years. You always believe that you can take on more and that you will always be able to overcome things. But there are no superheroes, no superwomans. And at a certain point, you feel like you're crazy, but you're not. The disease is crazy, not you. So psychological supports at early signs should be mandatory. Because if the intervention would have been done earlier, maybe only a psychologist support therapy would be enough for me. And I ended up in a black hole from where only a psychiatrist was able to bring me back. Thank you.
Thank you so much, Anna and Eduardo. So it's time to conclude. And I think that thanks to this discussion and this double point of view from patient and from clinician, we see what are the unmet needs in the field of Sjögren disease in childhood. And we have to work together on red flags for early diagnosis. We've listened to you, Anna, and to Eduardo, and also to work together for having collaborative assessment of long-term damage in patients suffering from Sjögren disease as soon as from early time in childhood. So again, I think that ERN Reconnect offers us a great opportunity to work together and to improve the daily life of the patient. So thank you for this very important discussion. And so we will have a new opportunity for a webinar after summer. So do not hesitate if you have some willingness to participate or to learn about specific topic, just contact us and we will organize this webinar. Thanks. Thank you.
Thank you, Gaetan.
Bye-bye.
Thank you, Eduardo. Bye-bye. It's been a
Bye-bye.
pleasure. Thank you.
Bye.